All right, so now we're going to move from the pathophysiology over to the pharmacology. And you can pretty much guess that we're going to be talking about dopamine, all right? Dopamine regulation. So those medications that we're going to use are going to target the dopamine receptors. And so we'll talk about typicals versus atypical antipsychotics. I'm sorry, antipsychotics. I got ahead of myself. Atypical antipsychotics. All right, and um, they're different. So I do think for this group of drug classes, you will need to do two sets of drug cards because we don't want you mixing up the first generations with the or typicals with the second generation or atypicals. All right, so typicals. It just when I think of typicals, I or first generation, I just think of the old drugs, the first ones, the ones that came out when we didn't know any better. But guess what? Those probably tended to work well, but had a lot of side effects. So when we talk about second generation drugs, we're usually talking about drugs that have improved upon the first generation of drugs and maybe even work in a completely different way. Mechanism of action might be completely different. And usually the goal is to reduce the horrible side effects. And let me tell you, if I haven't told you already, behavioral health drugs or mental health drugs often have the worst side effects, and they put you to sleep. Often they have to do with sedating the individual or working in that um, kind of limbic uh, center of the brain where kind of attention, concentration, all those things that we talked about before are located. So they happen to also kind of live near our sleep centers. So with all this temporal and frontal and inner brain stuff going on, yes, you're going to have crazy side effects, some of which are autonomous or autonomic, as we mentioned before in our previous lectures related to the central nervous system. Okay, so I really want you to take these seriously. These psych drugs are heavily tested on the NCLEX, even though you may never work with a psych patient or you will work with a psych patient because psychoses and psychological disorders are so prevalent, but you may never work as a psych nurse. So people often say, why is there so much psych on the NCLEX when we don't even, typically work with psych patients generally coming out of nursing? It's because your patients, and I like to think of treating every patient as though they do have a psych disorder, and just treat your patients as if you are scanning and assessing them for, um, you know, suicidal ideation, wanting to harm others, or other types of indications that a person's really suffering. Okay. So I said all that to say that psych meds are a big deal and that it's because we're in the brain. And there's so many side effects. So these first generation drugs, the prototypes are typically chlorpromazine or thorazine. All right. There are a couple of look-alike drug names with psych meds as well. So I'll pull some of those so that you guys can think about it as we get deeper into the semester, because this is the first time you're probably seeing chlorpromazine, all right, or thorazine. Haloperidol or Haldol. These two are very old and they've been in use for quite a long time. All right, and they're only good for those positive symptoms. So the primary mechanism of action with these are going to be a strong D2 dopamine receptor blockade. All right, so they're going to act as antagonists at these receptors. All right. They effectively reduce dopamine transmission to the brain, right? Right, which is what we want. And the therapeutic effect is a reduction in positive symptoms. All right, so the hallucinations die down, the delusions die down. Um, and those are linked to excess dopamine, remember? These two can also stabilize the sleep and appetite and help with the agitation. It's funny how stabilizing sleep is that's a desired effect, right? So putting psych patients to sleep not the worst thing for someone who's struggling with cognitive symptoms or struggling with those positive symptoms. Okay. And even the negative symptoms like anhedonia, right? Or problems with avolition. It could help to have sleep. Okay, so that's the typical antipsychotics. They block the dopamine receptors, the D2 receptors. I want to say too that this non-selective, and when I say non-selective, they go to all the D2 receptor blockers or receptors to block them. All right. They don't select the blockers that they go for. And because of that, that's really their biggest drawback. All right. There's a high risk of causing what we'll talk about more, EPS or extrapyramidal symptoms. All right. So, that's something I want you to just think about as we move forward, that because they're not selective, these typical antipsychotics, they're not selective to the receptor that they're going to block, that they tend to really have these blanket negative side effects. All right. There are some secondary effects of the typical antipsychotics on histamine, acetylcholine, and norepinephrine. So, because of all of these impacts, the net effect of the typical antipsychotics would be lowering dopamine. All right. And remember, that's what we want. We want an overall lowering of dopamine. Dopamine is overexcited. We got to lower it. Okay. All right. Therapeutic effects of the typicals are going to be what we mentioned before: less hallucinations, fewer delusions, improved agitation, all right, improved aggression, that frontal lobe impact, all right, stable sleep and appetite. And absolutely, if it's used, these typicals are used over time, it can prevent relapses, all right? And that's a good thing, right? Because the course of the disease generally involves some relapses. All right. So these typicals used to do a really good job. But then we got the atypicals. And so we'll talk about that. But first, I want to talk about EPS, NMS, in EPS. So EPS, we'll talk about adverse effects and include all three of these. EPS, NMS, we talked about sedation before. It is an adverse effect. And then orthostatic hypotension will be brought here, but I'm going to break them down in the coming slides. EPS, extrapyramidal symptoms, will include some of these bigger $5 words that are from our Latin and medical terminology: dystonia, right? Dys meaning somehow off or malfunctioning, dystonia. And tone or tonia refers to um, muscle tone. Muscle tone. All right. So tonia, it's also present. I won't get into it. I'll stay focused here. All right. Dystonia, I start thinking of all these other muscles that can have dystonia and cause problems. But let's just focus overall on muscles in general. All right. With dystonia, you experience rigidity or spasm. All right, rigidity or spasm or both. All right, so rigidity of the muscles acutely. So the person was doing fine at first, but they begin to develop an acute rigidity, or they start with the spasming. That will be dystonia. All right, akathisia. All right, restlessness, the inability to sit still. I don't see akathisia as much as a term, but restlessness, can't sit still, is. We might also call that agitation. Okay, so akathisia is agitation. All right, Parkinsonism. Parkinsonism. All right, it's, as you know, it refers to Parkinson's disease, which is really about it's a kind of neurological, and it's about tremors. All right, so if an individual is experiencing EPS, they kind of look like Parkinson's patients. They have this the spasms, but they also might get in the rigidity, but they also might get a tremor. All right, a tremor of the head, a tremor of the hands, just an overall tremor. Or you might see what's called shuffling gait. It's like where the individual cannot pick their 2 feet up off the ground. They're literally keeping the feet connected to the ground and just kind of like moving in a shuffling motion, all right, without lifting the feet off the ground. All right, so these are neuromuscular connections here with EPS. And then there's tardive dyskinesia. TD or tardive dyskinesia, those are the commercials that you see when you're looking at the game and you see those commercials about those people who have those uncontrolled face movements that they want to improve, or like the guy that's trying to sell, he's trying to show the people that he's selling to like a delicate teacup set or whatever, but his tardive dyskinesia is not allowing him to like pick it up and show it gently, like there's the tremors or the rigidity. All right, so they may even cause you to kind of tardive dyskinesia and EPS might charge like a tongue thrusting movement. They're kind of unwanted uncontrolled movements. And EPS is just a hallmark sign of use of typical antipsychotics. All right, this is something you got to detect early because it will really help your patient. All right, here's a graph that I put together to, well, not a graph, a table that I put together to just kind of help you organize the condition and with some terms that will help you understand the key differences. All right, now we haven't talked about neuromalignant syndrome, but I'll mention it here. It doesn't have its own slide yet. But neuromalignant syndrome, it does, but I haven't gotten to it yet. NMS is rare. It's super rare, but it's so life-threatening that we always test on it, right? And you're going to find after a while there's a trend in these test questions. You test on it because it's if you because if a patient or a nurse misses this in a patient, they die, right? Or we lose functionality of very important functions. All right. So with that said, we want to detect things early and we want to be the type of nurse who's kind of looking out for certain issues that might arise in our patient that has a certain pathophysiology. All right. So if you know they have schizophrenia and you know they're on typicals, you look for NMS symptoms. Okay. So NMS or neuroleptic malignant syndrome, it is life-threatening. It is a medical emergency, and it can happen at any time to a schizophrenic who's undergoing atypical medication or typical medication treatment. What does it look like? Hyperthermia, increased rigidity, right? That muscle rigidity, severe muscle rigidity. All right, altered mental status, AMS or altered mental status. What is altered mental status? Remember before I said if you're not alert and oriented to all four spheres, okay, and if you haven't heard of what the four spheres are already, all right, they're going to be to self, right? Do you know who you are? What's your name, Mr. Jones? Or what's your name? And he says, I'm James Jones. All right. That means he's oriented to who he is or self. All right. And then you might also ask them, what day is it? All right, so that means they're oriented to the time. All right. All right. They're oriented to or generally speaking, what time it is, or what, like the when. All right. Then you might ask them who the president is, right? Because you want to know if they're oriented to the situation. You may ask them, where are you? Do you know where you are? All right. So you want to know that they're oriented to where they are, who they are, what year they're in, like, and situation. All right. So why are you here? All right, is a good one. All right, so if they're not oriented to all four of those spheres, you might represent that in your notes. All right, to let it be known that they didn't know who they were. All right, and that's a serious one. We know that they're not oriented. All right, they're disoriented. And so when you say orientation or oriented from here on out, it's talking about their alertness to reality. All right, so a person who is experiencing NMS, to get back on topic, would be an individual who's altered or has altered mental status. Autonomic instability. All right. Do you know what that is? Autonomic instability. Well, that's what you see here with the increased blood pressure and increased heart rate. BP is always going to be blood pressure. HR is always going to be heart rate. Okay. So increased BP and increased HR or heart rate, those are autonomic responses. So if there's instability in their responses, something's up. All right. So you check that blood pressure, you see a blood pressure that is going through the roof, and that patient is schizophrenic on typicals, you're thinking NMS. Okay. Um, uh, Tachycardia as well. Tachycardia. And instability kind of refers to like the fact that they were down at one point and then up later and then maybe down again. So the instability refers to a rapid changing. So if the person has high blood pressure that's untreated, that's not the same as an acute episode of spiked blood pressure. Okay. The nursing priorities for all of these are going to include responding, being present, and understanding what you have going on and notify your provider. Okay, notifying the provider because whenever you're notifying the provider, it's usually because they can do something in their scope of practice that you aren't able to do, such as prescribing a medication, prescribing an order, transferring a patient. All right. So typically speaking, if you know that you've reached the limit of nursing interventions that you can do for your patients, you are going to pick the options that let the tester know that this is an emergency and beyond my scope of practice. I've identified this. Now I'm letting the team know that this patient needs to be referred over to medicine, pharmacology, ICU, whatever. Okay. All right. So that's NMS in a nutshell, and definitely check out that chart. Uh, to really give you the nice comparisons and how they differ. Okay, this slide also does that. Does that. All right. So just moving along, the nursing interventions were mentioned on the table, but I'll just highlight them again here. Early recognition is key. All right. What are we going to do? We're going to treat them with anticholinergics. And doesn't it make sense if they have an excessive heart rate, an excessive, a high, I said excessive, but I meant elevated heart rate, elevated blood pressure. Anticholinergics would help lower the heart rate, right? Lower the blood pressure. All right. So, anticholinergics, though, you're not going to give the patient blood pressure meds. You're going to give them anticholinergics, all right? Because this is an autonomic response and not necessarily the chronic blood pressure scenario, all right? So you're going to treat them with benztropine, which actually is an anticholinergic drug. We'll get to those eventually. All right, reduce the dose. That's a possible um, intervention for them, right? Holding and putting in requests to reduce doses. Or you might find that the pharmacy or the physician or the PA or whoever switches them over to atypicals. All right, so I do think it's important to know that you're going to be monitoring for TD. Remember, TD is a late version of EPS. All right, and once you get to TD, you're in, it may be irreversible. So it's really about documenting and observing that patient for the worst case scenario, which again, you're thinking rigidity, severe rigidity of the musculature, and or those autonomic responses like increased heart rate, increased blood pressure. All right, NMS, again, that's a little bit more definition or defining around there, but you see NMS, the fever, rigidity, and altered mental status. All right, we will see here as well. All right, notice that rigidity is present, but it's severe rigidity when you get to the NMS stage. All right, it's super rare. It is super rare. So, but just because something's rare does not mean it's a safety issue. And hopefully it's rare and we catch these early and therefore it's not as damaging. But usually the rare things are highly um, debilitating. So we definitely want to catch those things early.